are live on Facebook as well. So thank you so much for joining us today, everyone. I am Kay, the event manager here at the Chamber, and I am always happy to be here for in-person and virtual events. And we have a really great lineup this afternoon for this webinar. I would like to thank Atlantic Health and Morristown Medical Center for sponsoring this program, as they are bringing in very important and timely information. So with that, I won't take up any more of your time, so I'll pass it over to Dr. Thomas, who's kicking off the panel.
Thank you so much for the introduction, and thank you for giving us the time to present to you Atlantic Health's Executive Health Program. We're going to be talking to you about a customized approach to preventative medicine. As you know, your health is your most important asset. When we talk about preventative health, we talk about primary prevention and secondary prevention. Primary prevention is reducing risk by preventing the disease from developing. There are at least 4 components to this: nutrition, exercise, stress reduction, vaccines, good sleep. Dr. Padavan will be going into a little more detail with the nutrition and exercise, but generally speaking, you want to make sure that you're getting plenty of fruits and vegetables, you're limiting your saturated fats, trying to avoid red meat, pork products. When you are having protein, it's more of a plant-based nutrition. You want to make sure that you're exercising, whether it's a prescription that you set for yourself where you go to the gym and you do a certain amount of exercise, or just doing an activity that you enjoy. It could be in the form of running, biking, hiking, playing tennis, anything that you enjoy, just get moving. That's what we want you to do. And of course, stress reduction. We are definitely in a time where we're being pulled. There's a lot of external stressors with the pandemic. So finding that source for you, it might be meditation, it might be prayer, it might be playing a game with your children or your friends, some form of stress reduction. And of course, vaccines, which we all know about, and I'll go into more detail later. Secondary prevention is identifying the disease before it becomes symptomatic. When you come to your physical, the physician examines you, we check your blood pressure, your heart rate, we're looking at you, we're listening. So we're identifying things that could be a problem. We're also going to be doing blood work and of course, cancer screening. One of the pieces of blood work that we look at is something called a hemoglobin A1c. The hemoglobin A1c measures your average blood sugar over the previous 2 to 3 months. We're able to identify possible signs of prediabetes and, if not, actual diabetes. What is prediabetes? Prediabetes is a hemoglobin A1c in the 5.7 to 6.4% range. And overt diabetes is when that hemoglobin A1c is now 6.5%. Why is it important to identify prediabetes and diabetes? Well, this condition can predispose you to cardiovascular disease, putting you at a higher risk for heart attack, stroke, peripheral vascular disease. It is particularly important that we screen patients who are at higher risk, and that's going to be patients that are Hispanic, South Asian, African Americans, and of course, those with a family history. Women with diabetes have 3 times the higher risk of coronary artery disease compared to a non-diabetic woman. So this is something else just to keep in mind. In terms of cancer screening, I have to tell you that we have come a long way with cancer screening. We're able to identify cancer much sooner than it becomes a problem. The World Health Organization still has identified breast cancer as the most common cancer in the world. We are at 2.26 million cases in the year 2020. However, if you look at more local numbers, whether it's domestic here in the United States or even in New Jersey, that number is number 2 in incidence. And that's because we have great screening tests. We want every woman to get that baseline mammogram at age 40. Now, if you have a family history of breast cancer or in the family of that range, you want to have your first screening 10 years before that first degree relative was diagnosed. For example, you have a mother, a sister that was diagnosed with breast cancer at age 45, your first mammogram will be at age 35. And sometimes people ask, how often do I need to get this mammogram? The recommendation is every year. There are some soft recommendations about every 2 years. However, I find that it's hard to keep track of something if it's every 2 years. But if you know that you're going to be getting your breast cancer screening every year, it just makes it easier, and it's better in terms of identifying that any early cancers, we catch them early. We have very sensitive tests now with our 3D mammograms. And depending on the density of your tissue, we add an additional breast ultrasound at the time of the mammogram. And if you are then identified still at high risk, we will put you in touch with a breast specialist who can see if you qualify for breast MRI. Some women ask, when can I stop doing the breast imaging? And that's really a decision between you and your physician. After age 75, we say, you can decide if this is still some form of preventative medicine that would be beneficial to you. Cervical cancer screening. This is also something that's changed over the years. There was a time when we didn't have access to this very sensitive test that we have now, which is the thin prep. We also were not automatically checking for the human papillomavirus. We now have testing available to us that allows us to do both. So when should one have their first pap smear? A female should have her first pap smear at age 21 and then every 3 years. When you turn 30, we automatically test you for the human papillomavirus. And if it's negative and you're deemed low risk, you can continue to spread the actual pap smear out to every 3 years. Now, if you have an immunocompromised situation or you're taking medications that are suppressing your immune system, then you're at higher risk and you have to still have a pap smear every year. So someone might ask me, well, do I need to see the gynecologist if I'm not getting a pap smear? And I say, yes, you should still continue to see your gynecologist. And that's for the pelvic exam and what we call just a general well woman exam. Now, ovarian cancer is something that's been in the news. It's unfortunately, one of these cancers we don't have great screening tests for. However, there are some women who may be identified as being at high risk. So for instance, if you have a family history of breast cancer in both breasts, multiple family members that have had breast cancer, or you have a family history of ovarian cancer, you've had a family member who's had the diagnosis of breast cancer before the age of 50, you have family members who have had ovarian or tubal or peritoneal cancer, then we do have a screening program for ovarian cancer. Patients who have any type of positive findings on screenings, we are able to offer you genetic counseling, and which then leads to genetic testing for BRCA1 and 2. Colon cancer. This is the second most common cancer according to the World Health Organization. It's number 3 in the United States, but still something that we call preventative. Until recently, we were screening people at age 50, but after the American Cancer Society made a decision that we are seeing colon cancer at a younger age, we were able to reduce that age to 45. So the new recommendation is that any person age 45 can start their colon cancer screening. If you had a family history of a first-degree relative, for instance, a mother, father, brother, sister that had colon cancer before the age of 45, your first colon cancer screening will be 10 years before. So for instance, somebody with colorectal cancer in your family at age 45, you would have your first colon cancer screening at 35. The frequency of the colonoscopy depends on what is found during the colonoscopy. When I say this is one of the best tests that you can do if you do the prep right, the preparation is what we call the worst part. You have to drink a preparation until your bowel is completely clean. But when the gastroenterologist views that bowel, all sides of it, they're able to pick polyps, identify them, and say, send it to pathology. Is this a precancer polyp or a polyp that would not have gone on to become a cancer? So when you talk about the benefits of a cancer screening, this is sometimes what I call a real investment. Sometimes you get 10 years back on this colonoscopy because you might have a fully clean colon and that you do not have to go back frequently for this. In the executive health program, we also focus on osteoporosis and your bone strength. We do bone density screening and screen people for the stages even before osteoporosis. So there might be something called osteopenia, which is the stage before osteoporosis. Why are we worried about osteoporosis? Osteoporosis can lead to increased risk of fracture. And as you get older, that fracture can lead to increased morbidity and mortality. What can you do to avoid osteoporosis? 3 things. You want to make sure you are waking up your bone cells by walking. That's either walking, hiking, jogging, doing some type of weightlifting, consuming 3 servings of calcium-rich foods per day, and vitamin D with food. So you need all 3 because they work together. You wake up the bone cells, they use the brick and mortar of the calcium and D to build, and then you reduce your risk essentially. If you're unable to consume 3 servings of calcium-rich foods per day, then you can supplement with something like a calcium citrate. Citracal is a brand name for calcium citrate. It's just a more absorbable form of calcium. And of course, avoid things that might accelerate bone loss, such as alcohol and smoking. There are some medications that can also make your bones weaker, such as steroids, some seizure medications, and also some thyroid medication if you're getting too much of it. Menopause. So of course, we enjoy the fountain of youth for a certain amount of time. And at some point, you no longer have the benefits of estrogen. And some women become symptomatic. What can you do about menopause and symptoms? Consume lots of fruits and vegetables, trying to get at least 2 to 3 servings of a whole soy, such as edamame, tofu, tempeh. Make sure you're exercising. Exercise actually really cuts back on those symptoms that you might experience through menopause. There are some women who just still need a little bit more, and in those circumstances, you can talk to your gynecologist or metabolic specialist about a low-dose estrogen. And you would use that for the shortest amount of time that you would need. If you have your uterus still, you would use a combined estrogen with progestin. For the actual symptoms of menopause, if it's vaginal dryness, we can use something like a vaginal estrogen cream, a small amount, or a coconut oil or aloe vera. For hot flashes, the soy, the black cohosh, Remifemin is a name brand that's out there for the black cohosh that's available as well. And of course, there's also the SSRIs, such as Zoloft, that's available for hot flashes. But we try to go with a non-hormone approach when possible. I had mentioned the importance of primary prevention and vaccines. You probably think, oh, I had all my vaccines as a child. Do I really need any more vaccines? And as we know, there are adult vaccines that we keep track of. The influenza vaccine is one that you should ideally get every year around October or November, before flu season hits a peak. That's the best time to get the influenza vaccine. This past November, we had a higher incidence of influenza A than we had normally seen right before the Thanksgiving period. So those that were protected in the October-November time, benefited. Your tetanus, diphtheria, pertussis, you might have heard about whooping cough. Of course, you get 5 as a child, and then it starts to wear off. So we recommend at least 1 adult booster. If you have a new baby coming into the family, or you're going to be exposed to a new baby with a family friend or as a grandparent, you want to make sure you're up to date, that you've had that whooping cough portion of that tetanus vaccine. So that's the TDAP. The shingles vaccine, our old vaccine was a live vaccine. The new vaccine that's been around since around 2016, 17 is a killed vaccine. That means you don't have to worry about if you get the vaccine that you might accidentally shed it to somebody who's immunocompromised or a baby. You would get 2 vaccines here. They're separated by 2 to 6 months. So you get the first Shingrix and you get a booster shot 2 to 6 months later. The pneumonia shot is also indicated, Pneumovax 23, for some conditions, definitely age 65 and older, and then some younger people that have some gastrointestinal, rheumatologic, or some other form of immunocompromised situation, also asthma. And then finally, something that everybody's probably well versed in, that could probably discuss up here themselves, but the benefits of the COVID vaccine and of course the booster. Depending on which COVID vaccine you received, the timing would be different. And if you did receive the J&J vaccine, we still do recommend a booster, ideally Moderna, Pfizer right now. The Executive Health Program gives you an opportunity to have a full physical with all of the specialists that you need. As you can see from this list, we have access to the best in every specialty. 2 of those doctors are right here with us right now, and they'll be talking right after me. And we did talk about the cancer screenings. The good news is that almost more than 75% of all illness is preventable. You can eat a healthy diet, you will exercise, get your vaccines, be seen by your physician, and pick up anything that could be a problem as it's identified early. Now, the full day physical that we offer, in addition to what you might consider standard care with your own physician, that's a physical exam, lab work, EKG. We also do a chest x-ray, full skin check. You have a hearing and vision screen. Women undergo all of their breast cancer screening. They're made sure that all their cervical cancer screening is up to date. If you're a male, your prostate cancer screening is up to date. We make sure that your immunizations are up to date. If you have need for stress management, we involve that as well. Dr. Padavan and Dr. Blum will both be talking about the other components of our day, which includes a cardiac calcium score, lung function, bone density, carotid and abdominal ultrasound, fitness testing, and body composition, meeting with our physical therapist, and of course our nutritionist. You start your intake with our nurse. She comes to you at your home or your workplace at your convenience. She goes over a full history in terms of your medical history, your family history, your social history, your surgical history, all of your medications. She assesses your risk factors. She draws your lab work right there. That lab work is processed. And once all of that data is compiled, she meets with the internist of the day. They put the pieces together and they're able to build a complete executive health physical that is ideal for you. We try to help you in terms of your post-care as well. So after you've met with everyone that you need to meet with that day, you still have access to the healthcare navigator for follow-up and coordination of additional testing, follow-up appointments with specialists, and any additional information that needs to be obtained. Should you get sick during that time between now and your next well physical, our nurse navigator also helps get you a sick visits, sometimes same day, but generally within 24 hours. We ideally like to do the full day exam at least every 3 years. In addition to a comprehensive preventative evaluation and physical, we are incorporating the lab work, which includes a micronutrient panel, of course, the advanced imaging, which we will go into more detail, and an exercise regimen for you. The half-day physical is very similar. It doesn't include the specialist, but you have all of the other benefits in terms of a complete thorough exam with your internal medicine physician, lab work, some pulmonary function testing and EKG, your audiogram, visual acuity, a full skin check. We look at your body composition. We're able to tell you your body percent fat, Idexa, your balance testing called BioSway. You're assessed again by the physical therapist for fitness and flexibility, strength. You will also meet with the nutritionist, or you could choose to do the more of to find an exercise prescription for you with the EMR testing. The concierge service, as I mentioned before, gives you usually an appointment with your internist either the same day or by the next day. Our healthcare navigator is able to assist you with these appointments. They're able to help you get future appointments. And of course, you have access to the best physicians at Atlantic Health. If you need care outside of Atlantic Health, you're in another state, we can also help identify physicians in other areas for you. All right. Some of the data that we were able to obtain, that 9% of our clients were found to have some form of cancer, 31% were diagnosed with some form of heart disease, and 68% went on to have some additional testing, but overall we believe that 100% had overall client satisfaction. So now I'm going to introduce Dr. Mark Blum, our executive health cardiologist. Thank you.
Okay. Try again. Oh, there we go.
Oh, I'm sorry, I accidentally clicked out of that. Can you screen share again, Dr. Blum?
Screen 2.
Getting there.
And then you're going to hit. Okay, you have it. Click on. Wait a minute. No, go back here. Okay, you're good to go.
Okay.
Just down here to
So, Dr. Thomas, thank you very much. That was quite informative. I felt like I just went through 4 years of medical school, 3 years of internal medical training, and I don't know why I wasted my time now. I could have come to listen to your talk. It was wonderful and very, very instructive about what the program entails. I'm a cardiologist. I'm going to be talking for a short bit of time about cardiovascular testing and what we do in the executive health program in terms of our cardiac patients who come through the program, but this is actually applicable to everyone, whether they are in the executive health program or whether they are not. We have a very customized approach to preventive medicine, as Dr. Thomas outlined, and protecting your most important asset, your health, is what we're all striving for. I think, as you well know, Atlantic Health and Morristown Memorial Hospital are in the top listings of all cardiovascular programs in the United States for many, many years in U.S. News and World Report and by multiple other criteria. We're very proud of our heart program. I've been in Morristown for 33 years. At the time that the heart program really developed in Morristown and the surgical program began. And myself and members of my practice, including Drs. David Freilich, Drs. John Cosme, Dr. Leonid Mandel, Dr. Jason Solomon, and Dr. Joseph Forgione, are also available and participate in the executive health program in providing the kind of diagnostic and supportive care that our patients need. The program provides comprehensive diagnostic care and therapeutic care to all of our clients and all of our community members. So what do we do in our comprehensive part of the executive health physical? Well, from a cardiac point of view, we just doctors like every other doctor, we perform an extensive interview, try to identify any problems that may exist. We perform a complete physical examination. And then there are specific diagnostic studies which we perform and evaluate, including something like a resting echocardiogram, which is a sonogram of the heart, carotid artery ultrasound looking for any plaque in the arteries leading to the brain, an abdominal aortic ultrasound looking for any dilatation or plaque in the aorta in the abdomen. And we look at a lipid analysis of the blood work. So we're looking at cholesterol, we're looking at the breakdown of cholesterol and some of the newer screening tests that are available to our patients. We also perform a very instructive test called the CT calcium score. CT calcium score is a test whereby which we measure the amount of calcium in the coronary arteries. It turns out that calcium and plaque go together, and although a CAT scan cannot measure plaque because plaque is soft and is cholesterol, it can measure calcium, which is like a bone. And because of that nature of the two going together, we use the calcium score as an analog for plaque. We can identify patients who have a great degree of plaque who are asymptomatic and do need intervention in terms of cholesterol control and other things. We also have available, although not used routinely, but often put into play if things identify themselves as necessary, including a CT cardiac angiogram, which is a non-invasive cardiac catheterization, where we inject contrast into the vein and take pictures of the coronary arteries, looking for any obstructions in the arteries. We also have cardiac MRI available in Morristown Memorial Hospital and cardiac PET scanning, all of which take place if indicated. So what do we do in our interview history and physical examination? Well, in our interview history, we try to identify any cardiac risk factors. These include things like hypertension or high blood pressure that people are aware of, any elevated serum lipids or abnormal serum lipids, elevated LDL particularly, and elevated triglycerides, diabetes, as Dr. Thomas explained, either clinical diabetes or pre-diabetes put patients at increased risk for atherosclerotic coronary disease. We obviously screen for tobacco use and attempt to help our patients cease any sort of activity with tobacco whatsoever. We performed a detailed evaluation of family history of any cardiovascular disease, particularly in those families having cardiovascular disease at an early age, below the age of 60. We look at lifestyle. We look at patients who exercise. The American College of Cardiology, the American Heart Association both recommend a minimal of 30 minutes of brisk exercise daily, 5 days a week, and encourage our patients who are not doing that much exercise to begin. We look at any symptoms or signs of chest discomfort, either at rest or on exertion, shortness of breath, either at rest on exertion, and excessive fatigue. On our physical examination, what are we looking for? Well, we're looking at vital signs. We want to see if a patient has a rapid or a slow heart rate. We want to know about blood pressure, if it's high, if it's low, if it's normal. We listen to the heart and we listen to the blood vessels. We're listening for any normal sounds of the heart when the valves open and close. And we're also looking for abnormal sounds of the heart, suggesting any problems with the valve, either blockages in valves or leaking a valve, or in the place of blood, in place of blood vessels, we're listening for any sort of abnormal sound, which may suggest a plaque in the artery, which needs to be addressed. We listen to sounds in the abdomen. We look for swelling in the legs, swelling in the abdomen, swelling in the face, all of which may be early markers for heart dysfunction. We look for missing pulses in the extremities, in the arms or the legs, which may suggest vascular disease with blockages in the vascular system. We look for skin pallor or cyanosis, which may suggest that there's not enough oxygen going to the tissues. And we feel for irregular heartbeats, which can suggest arrhythmias such as atrial fibrillation, which is a very common cause of stroke in the adult population. So what is hypertension? Hypertension is, in layman's term, high blood pressure. The College of Cardiology has lowered the acceptable limits for blood pressure. In the past, 140/90 was the acceptable limit, the upper limit of acceptability, but it has come down, and we're now looking at 130/85 as an acceptable upper limit of normal for blood pressure. The lower, the better, and as long as patients are asymptomatic, frankly, if they're on the low end of blood pressure, we're happy and are not attempting to modify that. In terms of lipids, We look for LDLs greater than 100 or LDLs greater than 70 in patients who have known cardiac disease. We look for triglycerides greater than 150. And today, patients will come in, and many people still are very fixated on HDL, saying, well, I have a good HDL, or I have a good ratio of my HDL to my LDL. You can essentially throw that out the window. We don't look at that much anymore. While it is true that higher levels of HDL are associated with better outcomes, manipulation of HDL up to this point has not proven to be effective in reducing heart disease. So we're very eagle-eyed focused on the LDL numbers and the triglyceride numbers. In terms of diabetes, I think Dr. Thomas covered this, but we do look for an elevated fasting blood sugar, which is sort of a snapshot of your blood sugar at the time that the blood test is gone. But we're obviously much more interested today in the hemoglobin A1c, which, as she mentioned, was an average of 3 months of blood sugar levels. We would like to know if patients do have diabetes, if they have type 1 or type 2 diabetes, either they've become insulin dependent at a very early age, or as in our patient population, more likely they're sedentary and overweight and have developed type 2 diabetes, whether they use medications such as pills or they do inject insulin or some of the newer analogs of insulin. We screen for tobacco abuse, any abuse of tobacco products, including things which are not often asked for, but are used more than we like to believe, which is like chewing tobacco or snuff. All carry increased risk for cardiovascular disease and cancer, along with obvious risks of COPD and emphysema. And we provide counseling and medications and accessibility to smoke stopping clinics if our patients are interested in pursuing that avenue, as we would strongly suggest they do. We screen for a family history of cardiovascular disease. There's a very strong genetic component of both structural heart disease and atherosclerotic coronary disease. What is structural heart disease? Well, structural heart disease is something like a valve problem, something like a thickness of the muscle of the heart, or other parts of structure of the heart itself, not involving the arteries and not involving blockages in the arteries. We find that genetic testing can be helpful, particularly in looking at our patients who may have some sort of a cardiomyopathy. Cardiomyopathies are different diseases of the heart muscle, and there are more and more exquisite genetic testing available to our patients today, which had not been available before. And often advanced imaging, as I mentioned before, such as MRI, CT angiography, or PET scanning of the heart can be helpful in finding these patients who have these complicated structural heart problems. Sedentary lifestyle is something we deal with on an almost daily basis. People don't do enough of regular physical activity. I talked about the 30 minutes a day as recommended by the American Heart Association and the American College of Cardiology of brisk exercise. We're often asked what brisk exercise is, and it's really anything that raises the heart rate, from a fast walk to a treadmill, to a jog outside, to an elliptical machine, to a bicycle, either inside or outside, to a swim, or to a Zumba class if people enjoy doing that. But it's really anything that gets your heart rate up and keeps your heart rate up for a minimum of 30 minutes, 5 days a week. There's a strong association with cardiac disease in patients who are sedentary and do not exercise. It's the one thing that we encourage our patients to do for themselves. It's not something we can do for them. We can't write a prescription for another pill. They have to understand why it's important, and they have to engage in this on a regular daily habit. We look for obesity. We determine the patient's body mass index from their height and weight. There's a strong correlation with atherosclerotic coronary vascular disease, arrhythmias, and overall poor physical cardiac outcomes in patients who are obese. And more of that data is emerging all the time. At times, we may even encourage our patients to consider undergoing bariatric surgery to lose weight, as that can also help both reduce their incidence of concomitant diseases such as diabetes and heart disease itself. Our non-invasive cardiac testing that are done on a regular basis with our patients undergoing the executive health program include a resting EKG. An EKG evaluates the electrical activity of the heart. It can screen for prior damage or heart attacks. It can screen for irregular heart rhythms. and it can screen for electrical deterioration, which may require a pacemaker. An echocardiogram, as I mentioned before, is an ultrasound of the heart. It evaluates the size of the heart, the size of the chambers of the heart, the function of pumping chambers of the heart, and the valves themselves, whether they're opening and closing in a normal manner or whether they're blocked or leaking. We do both aortic and carotid ultrasounds, which evaluate the major blood vessels for plaque or tears, which are called dissection, both in the neck and in the abdomen. We do a treadmill stress test, which is used to evaluate potential significant plaques in the heart. And we combine this with an echocardiogram, so we get both the advantage of looking at the EKG during exercise and also looking at heart function before and after exercise. This gives us valuable information about the strength of the heart, the rhythm of the heart, and is a quite sensitive test. We do a blood lipid analysis looking at HDL, LDL, non-HDL, cholesterol along with triglycerides, and we follow that in response to therapy. Non-invasive other routine cardiac testings include CT calcium scores, which are a non-invasive way of looking at plaque in the coronary arteries. The heart has three main coronary arteries: the left anterior descending artery on the front of the heart, the right coronary artery, which goes to the bottom of the heart, and the circumflex artery, which goes to the back of the heart. Any and all of these vessels can be involved with atherosclerosis and plaque. The CT calcium score will show the amount of plaque in the coronary arteries, the location of the plaque, and the percentile blockage, or this percentile of plaque for an age and sex adjusted denominator. So if we're looking at plaque, we want to know, where do I stand for a man of my age, for a woman of my age? Am I in the 20th percentile? The 80% of people have more than I do and 20% less? Or am I in the 80th percentile, where I really have a lot of plaque and only 20% of patients my age and my sex have more plaque? It's a very valuable tool. It's an eye-opener to patients who don't think they have cardiac disease, and often a reassurance for patients who are worried about cardiac disease, who end up having a very low score, a 0 score. So we like it. It takes about 3 seconds to do. It's non-invasive. You don't even get an IV. You don't have to go into a gown. You lay down a gurney and pass through a CAT scan, and that CT calcium score is shot back to us in a very quick period of time. We also, as I mentioned before, have access to CT cardiac angiography, MRI, and PET scanning, all advanced non-invasive imaging modalities available at Morristown Memorial Center Gagnon Heart Hospital. We have excellent cardiologists who are skillfully trained in reading and interpreting these studies, which can give us valuable information in a variety of different situations. So what can people do for themselves? What can we do to encourage them to lead a healthy cardiac lifestyle? Well, as Dr. Thomas noted before, we evaluate their diet. If they're hypertensive, we encourage patients to decrease the amount of salt in their food. We want people to stay well hydrated, which is often a problem that's not well appreciated by a lot of patients. We encourage patients to exercise. We put patients on medications. There are a lot of medications today for things like blood pressure, things like cholesterol, which are well tolerated, asymptomatic, with no side effects. We do let our patients know that it can often take 2 to 3 medications to control their problems adequately, and to stay with us, stay with the program, because if they're left untreated, heart attack, stroke, arrhythmias, and kidney disease can progress. In terms of hyperlipidemia, diet and exercise are keystone. Medications today include not only statin drugs, which we all know about, and there's about 7 or 8 of them on the market today, but also things like monoclonal antibodies that have dramatic results in lowering lipids with no side effects, which can be injected by the patient every 2 weeks or 4 weeks with almost miraculously like results. These medications are tolerated if approached in a sensible manner. We certainly talk about multidisciplinary approach to diet, to weight loss, to exercise, with evaluation and formulation of prescription for ongoing programs. Excuse me. Last but not least, We have access to highly skilled interventional cardiologists and structural heart doctors. Today, cardiac catheterization is accessed through the risk with minimal discomfort or risk to the patient. It's usually a same-day procedure. We don't go much into the groin anymore like we used to. Patients are able to get around and walk immediately. Coronary and vascular stents can be implanted at the time of diagnostic procedure with minimal morbidity and strong efficacy. Today, I'm sure many of you are aware of the role of percutaneous transvascular aortic replacement, TAVRs. In the old days, when patients develop blockages in their aortic valve, which happens routinely in elderly patients, they would have to undergo surgery to replace the aortic valve. Today, this can be done percutaneously with one overnight stay in the hospital in a non-surgical manner, and has been a miraculous boon to our elderly patients. And last but not least, we have a very strong electrophysiology department in the hospital, which can analyze and treat arrhythmias with medications and with ablations of their irregular heartbeat. So the executive health program is a one-day program which minimizes health risks. It's a one-day program in a premier location providing integrated health examination, and it's a one-to-one day for our client with multiple doctors. The client themselves are the only focus, so please don't overlook your most important asset, whether it's through the executive health program or through visits with your primary care physicians and any specialists who are deemed appropriate by your primary care doctor. And on that note, I will turn this over to Dr. Padawan. And hopefully you're there, Dean.
Thanks, Dr. Blum. All right. Thanks, Dr. Blum. I always feel like my heart feels better every time I see Dr. Blum or a member of one of his teams, which is great. So thank you. Briefly, my name is Dean Padavan. I'm an internal medicine doctor with some specialization in sports medicine. And I've been working with the executive health program since 2015. As you heard from Dr. Thomas, as well as Dr. Blum, we have just some great, a great overall day. You have some great prevention screening, as Dr. Thomas mentioned, some great cardiovascular screening, as Dr. Blum mentioned as well. And it's a very collaborative program. So all the physicians that work together, we talk to one another to make sure we optimize your health. So this is our office site, which is 111 Madison, which is across the street from the hospital. You saw some pictures of our venue, but it's a beautiful venue on the 4th floor where you spend most of your day. Now, both Dr. Thomas and Dr. Blum spoke about Morristown Medical Hospital. We're very fortunate to be associated with such a strong hospital. Morristown is consistently ranked as the best hospital in the state and one of the best hospitals in the country. And what's additionally great about Morristown is that it has received a leapfrog A grade for safety, and it's also considered a magnet hospital, which is for excellence in nursing. So we're very fortunate to be associated with Morristown Medical Center and the Atlantic Health System. I know we're a little crunched for time, but my focus today, given my background, is going to just elaborate a little bit more on the musculoskeletal and nutritional evaluation when clients come through our program. As you heard from Dr. Thomas and Dr. Blum, they also ask about exercise because exercise is so important. It's so important to move. Just before putting these slides together, one of my colleagues had emailed me a recent study just showing that an increase in 10 minutes, if you're between the ages of 40 and 85 years old, of moderate to vigorous physical activity can decrease approximately 110,000 deaths per year. And that stat is pretty incredible. Yes, the goal is to get to 150 minutes per week, but even just moving a little bit can be very beneficial. One of the goals of the executive health program is also to find the barriers to exercise, right? So there's Obviously, time is probably the biggest barrier. A lot of our clients are very busy, but sometimes when we show them these stats, we can convince them to kind of fit in 5 to 10 minutes of exercise. But there are other barriers, and we look for them. And what are those barriers? Sometimes clients come in with a joint pain. So it's up to us to evaluate that joint to see whether or not we can kind of overcome it so that they can move and they can exercise. There are some people who come in who are fatigued, don't have energy. And again, that is also on us to try to figure, well, why are you low in energy? Are you not sleeping? Is there a thyroid issue? Again, we look for reasons that are causing your fatigue so that we can get you to exercise. A lot of people also come into the program and say that, I'm just overwhelmed. I don't know where to start. There's so many exercise programs out there. There's so many different gyms and types of exercise. What do I do? And that's where we can help you as well. And we'd mentioned, I think on a previous slide, that we have a great certified athletic trainer, and this is Kelsey, who takes you through a functional movement screen and actually a couple of different screens on your physical. And she assesses your strength, she assesses your balance, and she puts a really nice individualized program for you so that you know what to do, what areas are weak that you need to improve on. And again, it's an individualized packet that you get when you leave on your executive health day. And so this is great. But I think Dr. Thomas also mentioned balance. We look at balance all the time. And the reason we look at balance is because we don't want people to fall. This is our BioSway machine. And what it does is it compares your balance to people of your own age group. And there's 4 balance tests. You balance with your eyes open and eyes closed on a firm and foam surface. And it kind of gives you a rough score. And what this allows us to do is, again, focus on areas of weakness in your lower extremities to try to prevent you from falling. We also look at your body composition. This is one of our new machines. It's called the Idexa Machine. And it allows us to look at your percent body fat, but it also allows us to look at your lean body mass, so your muscle. What's really nice about this machine is that it shows us your distribution of unhealthy body fat. And again, a lot of us know that our unhealthy fat or visceral fat tends to accumulate around our abdomen. And if this is the case, it promotes some of those diseases that my colleagues were talking about. So metabolic disease, diabetes, cardiovascular disease. So it's a really nice individual picture of where you are in terms of percent body fat and lean body mass, excuse me. And what's really nice about this machine, as you come through the program, you get to compare yourself year in and out. So if you were through our program for the last couple of years, you can see the progress that you've made after you've been given the tools to try to improve upon percent body fat. So this is a really nice way to follow you along over the years. You also, on your physical day, get to meet with Cindy, who's one of our exercise physiologists. And you heard about these tests early on as well. You have a resting metabolic rate. You also have a Vo2 Max test. The resting metabolic rate, to me, is, in a sense, your metabolism. So a lot of people come in and say, I don't think I have a very fast metabolism. But doing this test allows us to actually determine the amount of calories you burn at rest. And we're allowed to use that value to really put a individual type diet plan together for you with our nutritionist, which I'm about to speak about. Your Vo2 Max testing, this is an example in this picture here. It's a way to test your aerobic fitness. And again, this is something that can continue to improve over the years as you kind of go through our program. It's a way that our body is able to maximally use oxygen efficiently. So it's something that we do with all our clients as well. And what I really like about this test, it gives you, again, you're going to hear me say this a lot, individual data. So we will be able to tell based on this test where you are able to burn fat and where you're actually promoting more aerobic fitness. So that's always really nice as well. I mentioned again on your physical day, you get to meet with one of our nutritionists. This is Susan Grilly. She's fantastic. And she takes the data that we just learned from those previous tests and again, really constructs a great way and a daily plan, breakfast, lunch, and dinner on how many calories you should be consuming. We all know that it's really important to eat a lot of fruits and vegetables, stay away from red meat, stay away from the saturated fats. But she really kind of specifically goes through breakfast, lunch, and dinner, and she works with you. There's so many people that come into the program with many different diets. There's a million diets out there right now, but she's able to work with what your goals are, whether it's to build lean body mass, whether it's to lose weight. She'll work with you based on the parameters that you get from your testing in order to accomplish those goals. And that's why it's really, really nice. We use a company that actually does specific micronutrient testing. It's called SpectraCell. And this company thinks that their values or the micronutrient values are better because you're actually testing these values using white blood cells. So you're not using the serum like normal blood tests. And it's a really nice way of showing what you may or may not be deficient in. And based on this test, again, they recommend various foods, and Susan reviews this with you in detail to tell you what foods and what nutrition you need in order to bring up some of your potential deficiencies. So I just want to end briefly by just talking to everyone about, who comes through our program. Again, we see so many amazing people, so many diverse patients. We see a lot of executives. We see individuals who call our program and just say, you know what, I'm too busy. I just want to get everything done in one day. And like Dr. Thomas and Dr. Blum said, we have a really, really great team here. We're very collaborative, and you're the focus. You're a priority through that entire day. We do see people who come internationally, and I can't tell you how many times we see people call us and say that, I had such a great experience. Can I send my wife or husband into the program because they just were so happy with their care? And alternatively, sometimes we have some really high-end athletes or an athletic population that come through that want to increase their performance or improve their performance. And they want to take the data and the metrics that you get from our program and kind of incorporate in their lifestyle in order to take it to the next level. So we have a great kind of really great diversity of patients that come through the program. And obviously we think it's such a great program because if your company promotes this, it's something where, again, people want to work with you, executives want to work with you. We think that it can definitely optimize executive productivity, decrease lost work days, and reduction in key man insurance. So we think there's many, many benefits that your company or you as an individual can benefit by coming through this program. So with that, I will conclude. You heard my colleagues say the same thing, that this program is here for your health. It's so many times and every day, and every person that comes to the program is so appreciative of, of this kind of entire, very comprehensive look at you, because it's definitely the most important asset. And we will do everything in our power to make sure that you're healthy, and we'll give you the tools to get there. So thank you very much.
Okay, thank you so much for presenting this. This was all a lot of information, and I feel like I have many doctor's appointments to catch up on after learning about all of these things I need to get checked out. So thank you so much. This seems like such a great comprehensive program, and I do hope that people check it out. So with that, I want to thank our attendees for tuning in today. Thank you to our presenters and the sponsor, Atlantic Health, and I hope everyone has a wonderful day today. So take care, everyone.